Okay, hello everyone. Just give everyone a minute more to sign on. We're just at 12 o'clock. This session is being recorded. Just letting you know in case there's any issues to attend the event. We will be posting it on the CHI website after the talk in order for it to be accessible to more people. So, welcome, everyone. I'm Kathy Eastwood. I'm an Associate Director for the Center for Health Informatics for Research and Strategic Partnerships. And today I'm hosting our speaker series. And at CHI, we focus on all aspects of the data pipeline, from data collection to analytics and custom displays. We aim to transform health data into evidence for the community by collaboratively working to develop innovative methods in health informatics science for precision health. This speaker series introduces the extraordinary work of colleagues in and around the field of health informatics. Today, our speaker is Samira Kahou, and she is an associate professor in the Schulich School of Engineering at the University of Calgary and a member of the Quebec AI Institute, also known as MILA, and a Canadian CFAR AI chair. Her research focuses on representing learning by decision-making, representation learning for decision-making, with an emphasis on explainability, generalization, and efficient learning, and has published in some of the top venues, including NER IPS, ICLR, ICML. She is the recipient of the 2024 Early Career Excellence and Research Award and the ACM-ICMI 10-Year Technical Impact Award in 2025. So with those, in even being early in her career, she's well acclaimed. And thank you, Samira, for being willing to speak with us today. For housekeeping, please put up your hand if you have a question to ask, or you can write it in the chat and I'll moderate those questions at the end of the session. Like I said, the session's being recorded and it will be posted on the CHI website under our events section. So please welcome Samira.
Thank you so much. I just check again if you can hear me well and you can see the slide.
Yeah, so Samira is having a little trouble with her mic, and the best thing is if you can't hear her, please just turn up your computer volume. Go ahead, Samira, and just talk loudly for us. Thanks.
So can you see the slides fully?
Yes.
Okay.
We see your title slide.
Okay. Yeah. Okay. I try to speak as loud as possible. So, thank you so much for inviting me and for giving the intro. So today I talk about trustworthy machine learning for clinical decision support. I talk about four of the somewhat recent works that I did in the intersection of health and AI. First I talk about the gap in clinical machine learning. So as we know, there has been a lot of advances in machine learning in health, like radiologists use AI for image analysis. Our clinical decision support system provide basic alerts based on electronic health records. But what is missing is that the direct treatment recommendation still is rare, and then the complex diagnostic ML seems limited adoption. This is mainly because we have trust barrier in our machine learning system that's kind of blocks our models in deployment. Now, there are four critical trust barriers. One of them is that the neural networks learning models, known as a black box problem. So we usually don't know why the model decides take certain decisions. There's also a lot of bias and fairness problems. So does it work for all my patients or just for some of my patients? There's lack of control. So can a clinician actually guide the recommendation? If they don't like, can they intervene? And then there's a performance gap. And that's the question of, is it actually better than my current practices? So my research in health informatics kind of today covers four aspects. One of them is that whether we can get interpretable intermediate features, whether we can have some sort of fairness by leveraging sensitive attributes. So we all know like bias is bad, but bias can also be used in machine learning to make some models better. It's just the matter on how we model them. And then whether we can enable clinicians to guide AI treatment recommendation through treatment goal conditioning, whether we can have human in the loop to use AI for their decision. And finally, I just talk about one of our recent works that I started at University of Calgary on fine-tuning very powerful generalist foundation model for like performance in a specific diagnostic task in downstream task. So basically, the goal of my research is to make ML systems that efficient and that explain themselves so you can trust and can adopt in the system. So the first section of my talk will focus on the black box problem. So the goal here is that whether we can make this reasoning inside the models a bit transparent. So this is very important because clinicians usually need to know why a model makes certain decision. Either there's classification or anything else, they would like to know why this has happened. So most of the ML models that you see today, they really lack interpretable reasoning paths, and they cannot really, clinicians cannot really verify or trust these kind of decisions. So a potential solution we did, and this is pretty known in machine learning as well, is to use concept-based explanation. So what concept-based explanation does is that it aligns the intermediate model representation with some interpretable concept so that humans understand midway why these decisions are made. This is good because it reduces the cognitive load so that gives some terminology that is familiar. And it's also allows this trust calibration so that you can see where the errors come from. So this is pretty important because even if your accuracy goes low, if the clinician knows that this interpretation, they can actually decide to override the decision of your model. So this is how generally concept bottleneck models look like. They're pretty well known in machine learning community. They're very simple. So you usually have an intermediate function. Here is a neural network that gives you certain concepts. These concepts are understandable for clinicians. So if you, for example, give a cancerous skin, then what kind of concepts you can predict is that is it yellow? Is it is it the size? So you can predict these kind of concepts from the patch. And then once you have these concepts, you can go from concepts to your diagnosis. So this is in this scenario, the clinician can actually understand whether if it's like instead of yellow, it predicts another color, it would see where that actually falling apart, and they can intervene and fix in an intermediate layer so that the diagnosis becomes more accurate. So that's the main idea of concept bottleneck. It's pretty simple. It's just have two networks instead of one networks. Now, so the challenges we have here is that what are these kind of, you always need a predefined concepts and what are the right ones. And then this information might sometimes be incomplete. So that if you, for example, try to have your first network predict a set of concepts that are not representing your problem, then that's become a challenging scenario. And then there is a clear trade-off between accuracy and interpretability. So every time you want interpretability, you lose a bit of accuracy in neural network. So again, in terms of interpretability, these are very good. It gives you like a transparent decision making. It enables intervention because on the middle kind of concepts, you can correct the probabilities, and it helps with the debugging. So you would actually see what's the problem is coming from. But then there are certain challenges, and that's where we did this research on to see whether we can address some of these challenges. So again, in terms of challenges, we can have like an overfitting problem and the concept leakage problem as well. So the overfitting problem usually happens when you don't have enough data and where you have, let's say, a disease or a cancer that's pretty rare and you only have 2-3 samples. So that also happens when you predict this concept. So if your first model overfits, clearly your second diagnosis also overfits. And then there's a concept leakage. So there's this term in machine learning that's called shortcut learning, so that your neural network always tends to learn something easy rather than making sense of what's actually happening. So in that case, if you have concepts in the middle layer, they can carry this kind of shortcuts to your label. So that's what we wanted to address in the research we did. So what we came up with is that we add auxiliary losses to our concept bottleneck to tackle 2 problems, overfitting and this spurious correlation. So the solution we added is that we added an auxiliary preconcept task. Can you see my mouse, or that doesn't work? It works? Okay. So this is our preconcept task, which means that here our first network encoder also has access to the diagnosis. If we do that, then this encoder gets direct access to your diagnosis and does not leak certain information to concept. So it's not somehow forced to build a representation that gets the highest accuracy with regard to your kind of diagnosis. So there is a extra loss here. So then there is less kind of a force on concepts towards the diagnosis loss. And then we also added the orthogonality loss on the concepts. If you have orthogonality loss, each concept has this kind of loss that they represent one concept and they do not encode anything of the other concepts within. Let's say if they are this kind, they're usually some sort of numbers and vectors. So if they encode both size and color in one concept, then that's something you do not want. This happens and kind of reduces your accuracy. So by just adding 2 losses to the concept bottleneck models, we actually showed that not only we get a better kind of accuracy, but also we improve the interpretability by having more precise concept predictions. So here is some results that I show that this is in terms of task accuracy. So when we have a standard CBM without the auxiliary losses, we had around 82% accuracy, and then with auxiliary losses, we managed to get to 84. And this is only for task accuracy, but we also showed for concept accuracy that you get a better performance in terms of concept. So not only your interpretability is better, but also your overall accuracy is also improving. So that's pretty important because it addresses the trade-off between interpretability and accuracy. So now I go to the second work that I did recently with an intern this summer at U of C, and that is one-size-fits-all bias. So we all know that there are kind of differences in performance across subgroups in health and AI. So clinical models often perform really good for some demographic subgroups, but not for others. That's pretty much depend on your data, where you collect them, what's the population statistic, etc. So the standard approaches either use separate models for each population, subpopulation. For example, you can train one model for women, one model for men, and say these are two different, so I prefer to have several kind of models, and I use them, I modulate them and use them depending on my patient characteristic, right? Or some people just decide, say, oh, I have so much data, I don't care, and I just train a single model. Usually only having a single model really harms some of subgroups. So if you have a minority within your group, you would see the accuracy is lower within that subgroup. So we came up with one idea that is that was well known back in time in meta learning and few shot learning, to modulate, to have several networks that modulate each other to help addressing this problem. So again, I say without introducing harm, but I say always careful, because again, all of these things have been studied only within the data sets we're doing. So it's not like we call it towards, so that we're not saying, oh, this is a ultimate solution for that. So what we did is that we proposed a framework. So here we have 3 networks instead of having 1 neural network. There is one network on top that gets your input, and it tries to predict the sensitive data. So like predicts the age and sex, for example. So your first network is basically a discriminative model that's given your data, it tries to understand what's your age, what's your race, etc. Usually these biases are bad, and we always say this is bad, but in diagnosis and in health, we really need these kind of biases. Then we have a bridge network. This bridge network takes the representation of your discriminative network and turns them into a large vector. Those are known as biases of your third network. Your third network is the one that actually does the diagnosis. So we add these biases to your third network, and then we show that this actually solves the baselines that people showed, that if we have one network, it's kind of harm subgroups. So again, we still have that network of the diagnosis. The only thing we do is that we have a discriminative one that gives the biases vectors, and we add them to the third one, and then we show this somehow solves the problem within those data sets we studied. So this paper was a workshop paper, but it's currently under submission, so I hope we get positive review. So we tried on 4 different data sets. We have heart, SAP, diabetes, and mimic with different features. So these are just like basics that how we split the data and how we experimented. We picked this kind of statistics because there are other papers within this domain that we wanted to kind of compare with. So here I show the result, and like we have different baselines, and we show that like our bias modulation network kind of solves. It's not that it outperforms all the time, but it solves the gap of lower accuracy for certain subgroups. So like if it's old and male, we still kind of have the green. That's like the gain that we computed. So that's all about the bias modulation idea. And then if we like compare with the DCP, which is like a decoupled model, which you would say, oh, I have these many different combinations, and I would like to train 10 models for each of them. Then we show that by doing this bias modulation, we actually address the problem in 14/16 subgroups, and comparing to DCP, one hot, and the other baseline. So one hot baseline is just like you encode age with one hot encoder and you feed to the network. So again, this modulation is slightly better than just feeding those in terms of both security, and also it's more scalable. So if you get more data, personal data, you can train your first network, and that becomes a better discriminative network to gives you better biases to be added to your diagnosis network. So that was the whole idea, and we just showed that it works on certain baselines. Um, check, yeah. So that's leads me to the third work, and that is where you have lack of clinical control. This is the work I did when I was in Montreal. So I moved from Montreal to Calgary last year. And in Montreal, I was working on building methods for ICU. So there we wanted to build a model for drug dosage recommendation. So again, the motivation here is that the critical care is very dynamic. And there's some studies that says deviation from clinical protocol can be beneficial. And the idea is that, like, if you, for example, look at mimic dataset, there are clearly a lot of failure sequences that lead to failure. So while you want to mimic your clinician, but you also wish to be better, so that not every so that every patient has the survival um, possibility. So that was the idea of building this framework, and it's uses reinforcement learning, but also has this kind of a personalized treatment. So what I discussed so far were all supervised learning models. Supervised learning models, unless you decide to have different networks in between, they enable intervention, but they do not kind of, by design, they don't combine intervention. Whereas in RL, there is a control. You can take an action, and then like you can control the outcome. So we looked at what we could do, and then we've decided that RL methods are a good fit for such sequential decision making. And then RL is like there are methods for learning policy, and then they usually are known to learn via trial and error. And then this kind of enables clinicians to somewhat control through the recommendation and get the recommendation they want. So this is like just what is RL. As you probably, some of you know, it's a learning paradigm. It's one category of machine learning where there is an agent that interacts with the environment. So the agent observes current state, takes an action, and that takes you to the new state. And then you receive a reward. And the goal is usually to just maximize this policy of the action that you take so that you get the better cumulative reward. There's certain challenges that are known in RL and a lot of researchers are working on, and that is like rewards are not always immediate. Like if you, for example, you're someone who is very conservative in terms of like saving, you decide to save money in a way that your reward comes a lot longer in life. But in that case, you receive a reward very late, and that's very difficult in terms of learning if you're actually doing the machine learning part, because that causes the credit assignment problem. So that during all this episode, you actually don't know which kind of your action was the best towards that kind of goal. Then agents usually learn through trial and error, and that's not good when you're in healthcare because you cannot do a lot of trial and error scenario here. Sorry, one thing. So that makes two kind of factors very desirable. First thing is that you want safety, and the other one is efficiency. So you don't want to. This also valid in self-driving car scenario that you cannot get a lot of accident examples to train your model to avoid accident. So that's why its efficiency is very important in that case. So how did we design our model for RL? In this case, we just said our states are patient data, demographic, or vital signs. The actions are 5 dosage options for IV fluids and vasopressors. These are known in mimic data, so we used it from mimic. And then the reward are just non-zero at the end of the treatment, means like whether they are survived or not. And our policy maps our states to action to maximize return. So our goal is to receive that +1 so that we make sure the patient is surviving. So So for that, we used a type of reinforcement learning that's called upside down RL. Is pretty advanced in RL kind of research, but just to give you like a very high level kind of how does it work, and that is like in regular RL, you map your states to action, and you want to maximize the return. You want to maximize your reward. Whereas in upside down RL, you actually give the reward as a desired reward you want. So you tell the model that I want my patient to survive. Can you give me the action? So every time you kind of maximize your policy, you tell your neural network, I want the patients to survive. So that makes it somehow useful for your clinician to kind of intervene. But that's a very kind of easy example. So for in terms of machine learning model, we use decision transformer. That's pretty well known in literature, which autoregressively generates future action, and it is conditioned on desired return. This model is an offline RL method, so it's trained on a fixed data set. We're not interacting with anything. So we collected all these data sets, and we got it from, some of them are from Mimic, so that we just train our model on that. This is how it looks like. So you have the reward here that is +1 or -1, which is the survival. And then you have the state. This state just includes your vital data of your patient. So given these two, this is the vanilla decision transformer, you want to get your action. And your action is that which drug dosage I recommend to the patient at this specific moment. So we have the 4-hour interval between time steps here. And then these are the details of the model. So we have masked self-attention like a lot of transformers have, which means at the time step T, we only look at the past. We do not look at the future data, and that's how we optimize the model. So this is the vanilla decision transformer. We adopted this problem to drug dosage, but we also made some sort of a small modification. So again, as I said, the problem of having only one reward is pretty huge in that case. Let's say you have a patient that's admitted to ICU for 2 days, and then you have 2 days of data, 4-hour interval, and there is no signal to learn anything from. That's why we decided to have an extra reward to go here, and we call it acuity to go. So this is a vector score that indicates the status of patient. So there is this metric SAP2 that you can compute, and then you can use that as a reward. So this acuity to go is something you give to the network, and you get the dosage recommendation, so that the clinician can say, oh, what I want the outcome, like what I want some of these factors to be, so that they have a control over the network. So at the test time, this gives the guideline. But this is pretty difficult model, I would say. It comes with a lot of instability because you can't break the model easily. So if the clinician gives the acuity to go not within certain threshold that are, let's say your patient just comes to ICU and you give the acuity to go like to be like a healthy in 4 hours, that's almost impossible. So that can break the model. So there are some future works that we are looking into that, how to add safety to these kind of models. But then it's also like the second kind of this slide shows one way of how we can tell the clinician that what acuity to go they're kind of using might be not ideal. And that's the reason, like in any machine learning scenario, when you train on your train set, if your test set is very different, you actually break your network. So you need to always stay in some sort of a distribution of your train set. So in order to do that, we decided to define a new transformer network on top. This transformer network doesn't do much. It just gets your state and action. An action is just your current drug dosage recommendation and the state, and predicts the second state for you. And you train it on the train set. So it does nothing. It just says, oh, currently this is the patient situation. I give this drug dosage. What do you think would be the next state? This is pretty useful on test time because the states do not exist anymore. So it actually tells your clinician that, oh, now that you're offering this acuity to go and this drug dosage, there is this possibility that the network thinks that would be the next state. So if the next state is pretty unrealistic, they can adjust the acuity to go. Here are some results that we have. So this is the clinician policy, and this is our METI policy. It's pretty similar. It's just that again, I cannot kind of explain completely because we never tried that in at ICU, but our model has tendency to give less dosage in severe cases. So the purple is actually the clinician and the green is us. So there are some studies that says they are always high dosage in ICU, but whether we actually discovered that or not, we never studied that. But that's how our model thinks that in some severe cases, it does not want to give the same dosage as the clinician. And then in terms of stability, also we showed that MET-T has better stability comparing to other kind of machine learning, like behavior cloning is just, if you simply clone the clinician, DT is that does not have acuity to go. So we have a better numbers in low severity and medium severity. We also have some figures for interpretability. They're not perfect, but they just simply show that the attention weights actually look at every kind of reward that we give. They also look at the acuity to go, so they actually take account of what we want to modify within the network. Here is the future work of what we want to do on METI, and that is like we pretty much know that there are a lot of factors in the on mortality, and that's as a stochasticity. So one idea is that we condition on the average cluster instead of one individual, so we get a better kind of accumulated statistics. Then we also want to improve the explainability because attention maps are known to be very noisy and buggy, so you cannot really make decisions based on that. And then does factoring in treatment duration help? So for now, all you can do is just 4-hour treatment. So if the clinician would say, what about 8 hours, I want to make a plan, then that should be accounted in the network, which we don't have it at the moment. Okay. Now this is the last work and something currently we're working on with at the U of C, and that's focuses on computational pathology, and that is how we address performance gap in specialized domains. So so as you're probably aware, nowadays there are like foundation models for almost everything in healthcare. So, but the question is that if I get this foundation model, does it work for my downstream task? Do I need to retrain it? What are the options? So here we just did a simple study, and that is we get a generalist AI model on whole slide images, and then we saw that they actually struggle on brain histology data. So that was our goal, is that whether we can get a general purpose foundation model and we can adapt it to what we wanted for our own task. Then there are other constraints. Let's say if you're in academia and not have access to a lot of GPUs, do you have to train this from scratch, or are there like other methods for fine-tuning that you can do to adapt that? And then how can you add some sort of explainability to better understand why these decisions are made? So what we actually are working on, again, I told you we're working on computational pathology, and that's because we want to apply what we are developing to Calgary Brain Bank in future. So we're trying to scan more and more data and like get the ethic approval and then try our ideas on that. The technical challenge again here is that, as you see, like if you have a whole slide image, they're pretty big, they're gigapixel, and if you want to crop them into tiles, you usually get 100,000 of these tiles, and processing them and putting them together is very, very difficult. So that's why we're proposing some sort of kind of methodology fine-tuning on how we can adapt it to this specific task. So here is basically Eagle. Eagle is one of the known foundation models in mostly a framework. The foundation model itself is Virtuo 2. For computational pathology, Virtuo is pretty strong. It's a multi-scale general purpose. It contains almost every cancer data in it. But we show that this is if you want to only do work on brain data, and in this case we're working with eBrain, the European Brain Bank, there is still room for improvement, and that's what we did. We added LoRa fine tuning to this Virtuo, and then we run it through the Eagle, and we saw that there is still good enough performance to gain. Here is like how we the two kind of key things that we did to adopt the pipeline. The first one is that we average the virtual features of top 25, and then we feed it to a classification layer, and then we also added LoRa. LoRa is known in LLMs for for fine-tuning a very large language model, or in this case, a foundation model, to something to your downstream task. It's efficient, so you don't need to train it from scratch. So you can plug these Lorang matrices anywhere in your network and try to adapt it to your own data. So here is the result that we show, that by using this kind of fine-tuning to eBrain, we actually improve the performance. So you see, especially in the rare disease, we got a lot of improvement by fine-tuning only to the brain data. And the key findings again is that the accuracy is improved. We only analyzed top 25 most informative of these slides instead of 100,000 of them. And that's when through one of the modules that comes from Eagle that finds the more discriminative patches for you. And then we also use LoRa for Virtuo 2, which helped. And then this allows us to kind of only update a smaller number of parameters, not to train the fine-tune or continue training. So that was the key finding in that. So here is the conclusion, and that is there's always still a lot of challenges in leveraging the advanced machine learning to deployment. We focus a lot these days on interpretability, fairness, and understanding the decision. And anything ongoing should actually look at all together, whether you can get explainability while also improving your accuracy together. So I would say if we just focus on one, we might miss the other kind of component in our research. Here is my group of students. Some of them are still in Montreal, but majority are now in Calgary. And these are the source of funding we used for all of this research. And finally, thanks for listening. If you have any question for collaboration or supervision or hiring of students, you can write to me, but then I can go back to question. I think I should have talked for 30 minutes. I'm not sure.
You were close, not too bad.
Yeah.
If I'm too loud, you may have to temper your volume. I'll try not to speak too loud. Thank you, Samira. The forum is open for questions. This has brought up a lot of different methods, and I like that about this particular talk, as you dove into some experimental things you're trying. If there's any ICU or sepsis researchers out there in the mix, please chime in. I was particularly interested in that study. Anybody have a question at the moment? I wondered, oh, we have maybe Elliot. Elliot, would you like to open your mic?
Sure, I'll try to talk quietly too. Thanks so much for the talk. Very interesting to see all the different projects you're working on. Have you tried to work on any implementation sort of things with clinicians? Is there any examples outside of the mimic data and these data sets that people sort of use for examples all the time?
If I worked with clinicians on that, was that a question?
Yeah, if you tried to, yeah, exactly, solve their clinicians' problems, or try to implement these in actual systems, or use more non-mimic data, or these data sets that people don't, use very often or use quite often for these examples, because it seems like a lot of of these models are built on mimic all the time, so it's sort of they're over-tuned to mimic data, it seems.
So there is a reason for that, and that is I think mimic is the biggest, it's the largest data set available and to public that you can first build your method on. At Saint Justine Hospital in Montreal, we designed this model in collaboration with Saint Justine, and we built it in a way that can be adapted to their data set whenever that becomes available. But I would say in ICU specifically, getting data is very much more delayed than any other scenario, because it's we were close to collect a lot of data, but then I left here, so I don't know what has happened. But the way we developed the model was actually with this goal that we would deploy it and we will train it on our data and in Saint Justine. But again, if you ask me, I would still keep it pre-trained on mimic and then fine-tune it on that to get the best out of it, because it will take years to get the same amount of data from your own ICU than the scale of mimic.
Maybe another question. I know you used accuracy as your metric for most of those. Have you looked at other metrics? I know PPV and specificity or sensitivity are often used in healthcare because they're so imbalanced, these conditions, that you'd expect you get a high accuracy just by guessing negative every time.
I think in the ones that I presented, we used what has been reported to compare with, in terms of bias modulation techniques, for example, we report on accuracy and accuracy per subgroup. So that was used because to compare with other baselines, that's just the standard that other people are using as well. In terms of the METI, we're computing SAPS2 metric. That was something I was told by our clinicians, that this is a known metric of health measure. That was what we used. So again, I'm the AI person. So yeah, in terms of sensitivity, we kind of, all we do usually, we report the standard deviation, but not if you're referring to sensitivity or F1 score, no, we did not have it in these studies specifically.
Hey, thank you.
Any other questions? Two comments that come to mind, Samira, is that we do have some researchers in the Center for Health Informatics looking at ICU patients and sepsis in particular. So I can connect you with them as far as perhaps being able to test your models on real data. And well, on Alberta data, Mimic is real data. It's just often American based, right? And that, I had a question if you're, again, the ICU study, which is sort of the one I understood the best, is you're using more variables than just vital signs, or like you mentioned vital signs, but then in other places you included other systems that we're feeding in. So is it other clinical information or just vital signs that feed your models?
The vital signs are our input, whereas we SAPS2 measure, let me find it. I probably removed it from this and I forgot what is exactly. Is a metric that's just used by clinicians. So it's called simplified acute
like a score?
Score. Yeah,
Okay.
that's what we are using to show whether the drug dosage recommendation led to a better. It's some combination of your vitals, this measure. I do not
Okay.
have the exact definition, and
Okay.
to be honest,
That's
I'm not a medical doctor. Sometimes I cannot pronounce them as well.
well,
So
it sounds to me like various
yeah,
clinical conditions or symptoms feed into that score, and then that's part of the information feeding into your models. Okay.
that's what we use for measuring whether the action. So you say you want acuity to go, you would say, I want this much improvement in the vitals, and then that gives you the drug dosage recommendation. But this might not be a realistic scenario. For in terms of safety, we also feed your the current state, and the drug dosage recommendation to the second neural network that actually tells you this might be the SAP-S that you might get. So whether it is realistic or not. So that's why we computed the second one.
Okay.
The doctor, so then the doctor stays in the range. They cannot say, oh, I want I don't know, someone with sepsis in 4 hours complete recovery. So they can be very like they can enter an outlier to the system, right? And that
Right.
would definitely break it. So that's the problem of currently our model has. It doesn't know a clear threshold of what you can expect. That's why we came up with the second network that gives you the warning, and that's where we use this score. But
Okay. And you mentioned at one point that it generates a large amount of data that we may not have the GPUs to handle. Are you using ARC or some of the cluster computing available through research computing? Because we do know that they've purchased some fairly powerful GPUs for this kind of work.
yeah, so we are using ARC.
Mm-hmm.
I have my own RG Compute Canada, which is also decent.
Okay.
And I have access to the AI clusters of Compute Canada. So currently we're using the AI clusters of Compute Canada.
Okay.
Those ones gives you 4H100 in parallel. And I submitted a CFI, so we're pretty well equipped, but still these kind of things are very expensive. So you might end up with only eBrain, I think, gives us 2 million tiles that we could not process. And hopefully in Calgary, we will scan enough to be at the scale of eBrain in 2 years. I don't know. And but still, like in terms of compute, it was like not easy.
Okay.
If anyone needs help in compute that I can help, they can write to me if they want to know more what's available. Arc is also good, but Arc it has its own limitations. So
Right. Good. I'm glad you're aware and using that. Also, would your GPUs or that you have through your CFAR, is that available for other people to use?
I think they're going to make it available, but if anyone needs it, they can write to me and
Okay, talk to
I
you
think,
directly.
yeah, there are possibilities. So
All right, she's willing to share.
yeah.
Okay, any last questions before we close our session?
I also have Denver resources. They told me anything for health and AI, they're happy to. So I personally think anything AI for good, we should share as much as resources we have to.
Sure, it's just such a fast-moving field that we all need to pitch in and help each other with that. Well, thank you, Samira, and I'll close there and put in a plug for Jesselyn Holodinsky. Oh, there's a question in the Q&A. Sorry, let me go to the Q&A. It's just a different little panel. Aha, from Mina. Thank you, Samira. Could you explain a little bit more about introducing bias in your method?
So the idea, one second, sorry, I keep losing the page. So the idea is very simple. Like if you think that there's a general distribution, that's your ideal distribution of the world, then that would be where you actually have access to everyone's and you can model it perfectly. But you do not have that, so you have only like some distribution of that. Then you're ideally what people do is that per distribution, let's say only for women, they train one model. Only for men, they train one model. If you're doing, for example, skin cancer, there's some studies that shows that there's you get a lot more false positive if you have fair skin, for example. So there's bias affecting anyone in this scenario. So that's why people say, oh, let's us train one model per subpopulation, and then we use that for our own patient. I also find it pretty aligned with human intuition that we usually go to a doctor that's from our own language or race. We make this assumption that they understand us better, right? But what we did here, instead of that, we say you do have this general purpose network. What I do is that I have another network that is discriminative, understands your race, gender, and that one gives the bias to shift my other network so that I can shift the distribution of the last network. So then I stay within that kind of subpopulation and I predict something better. Again, I would say it's not ideal because we do have a small amount of data to train that, but within those kind of data sets, we show that it addresses that problem. So you don't need to train one model per kind of subpopulation because that's not scalable. Every time you come up with something rare, you need to train another model. Does that make sense? I don't know if I explained well. So.
That's all right. I think so. I was just putting information in the chat about our Jesselyn Holodinsky's AI Rounds podcast that also may be of interest to those on the call today to further the conversation. Tune in to people in and around U of C doing this kind of work, as well as other topics that she covers for related to education and AI and how it's used in post-secondary. Anyway, thank you so much for attending, everyone. Thank you, Samira, for your efforts today and all the best in your program of research going forward. Stay in touch. Feel free to contact her as needed and share this talk on the website once the link is posted. Thank you. See you all now.
Thank you so much for inviting me. Thanks.
You're welcome. Bye-bye.